Good afternoon, everybody. Welcome to CervixCheck's webinar on understanding the cervical cancer screening guidelines. We've currently muted everybody at the moment, and we will unmute everybody at the point in time where we start to answer some questions towards the end of the hour. So my name is Kim Templeton, and I'm just trying to advance the slides here. My name is Kim Templeton, and I'm the manager of CervixCheck at CancerCare, Manitoba. I'm here with Leslie Dick, our health promotion specialist. You'll find her hiding in the corner to the right there on the picture on the left. And I'm also joined by Dr. Lotocki, who is the lovely-looking gentleman to your right on the screen there. I'd like to first extend my gratitude to both Madeline and Leslie for all of their time to organize this great event.
Darcy, Anne Lavin, and Gaetan Touchet
has joined the conference.
And we have the audio. So that might fit. We're just going to attend to the audio here, folks. Everybody, I think.
You are no longer muted.
Function and a view join. You're not going to take a message. They're just getting things set up, she said. Okay.
Can everyone hear us okay?
Yes. Yeah.
Can we talk in? We don't have a microphone.
We're going to mute you
for Randy Blair, press 269. For Jody Cutero, press 303.
So that we don't have any audio.
Has joined the conference. Press 0.
Yeah, they're going to.
For Melanie, press 1.
Right
for Taranis, press 2. For Colleen, press 3. For Kate, press 4. You are now muted.
So we can just keep this open right now, correct? And we can continue to mute all if you want. Yes. Look at it this way? Yeah, we can. Yeah. All right, folks, sorry about that. We're just having some technical difficulties. We're excited to report that we've got 90 people registered for the webinar today, participating in over 30 communities in Manitoba, so it's very exciting. The webinar is accredited for one Main Pro M1 credit. You'll need to have logged in to the webinar with your first and last name in order to receive a certificate of participation. If you have not done that, please just call us and we'll make sure that you do get that certificate. As I mentioned earlier, we will be holding off questions until the end of the presentation. However, I would encourage you to please use your chat function, which is located at the bottom right-hand corner of your screen. And while we're going through the presentation, if you have any questions, just please enter it in there and send the question to everyone, and we will attend to those towards the end of the presentation. So we're going to get started. We're going to be talking today about the new cervical cancer screening guidelines as issued by our program, as well as the Canadian Task Force on Preventative Health Care. That were issued in early January of this year. We'll also be talking about some of the benefits and harms of screening with the Pap test, and hopefully we'll take some time to help you understand how to facilitate a discussion with your patients about what's right for each individual woman when it comes to the screening. So I'm going to hand it over to Dr. Lotocki. Dr. Lotocki is CervixCheck's medical. He is also a professor at the Department of Obstetrics
the doctor's assistant,
and program director of
the for Lori in the research
gynecological oncology.
To repeat this menu at any time, press 8. For all other inquiries,
at the University of Manitoba, he is head of the Division of Gynecology at the St. Boniface Hospital, as well as a past president of the Society of Gynecologic Oncologists of Canada. And as I mentioned, he is the medical lead of CervixCheck. So I'm going to hand it over to you now, Bob.
Thanks, Ken. Good afternoon, everybody.
The conference is on.
You may sort of wonder why we're changing guidelines, but guidelines are like a moving target, and screening guidelines are a moving target. Our knowledge base has increased over the years. So 30 years ago, we were encouraging women to have Pap tests, and we've been pretty successful in doing that. But unfortunately, what it's also done is we've reached women having Pap tests on an annual basis, while we've failed to reach people who aren't having Pap tests at all. Now, most of you, or some of you may have seen this article published in the CMAJ Journal, January the 8th, that basically was the Canadian Task Force on Preventative Health. And one of the reasons for talking about these guidelines is that I'm not sure that a lot of jurisdictions in Canada are going to be supporting these guidelines. And I'll basically present them first and tell you where our guidelines are and where we're going. So the Canadian Task Force basically was it's a group that had been coming from the Health Canada division, and it's a number of physicians and epidemiologists that have come together to look at what the literature shows and what would be recommendations based on the literature. And what you see in front of you is the guidelines that they've recommended for, in essence, starting screening at age 25 and not screening women less than 25 years of age. And again, they present their recommendations in terms of being strong based on evidence that they've put together. Well, unfortunately, I think this was a missed opportunity for Canada. It was not pan-Canadian, and that it didn't have representation from across Canada, nothing from the screening programs across Canada, plus the relevant societies, family practice, Society of Clinical Colposcopy, Gynecological Oncology, the SOGC. So in essence, this being a small group of individuals working at Canada Health. They made some assumptions that, looking through the article, that I would sort of pick out as sort of being problems, and that these apparent assumptions that they made were that Pap test sensitivity is high, that all abnormal Pap tests, whether it's mild or high grade, are equal in terms of impact. They unfortunately did not look at how the management and identification of high grade lesions would have on the incidence of cervical cancer, and virtually this is very difficult, if not impossible, to do in the literature. They define colposcopy as harm, and for the most part, there is harm with colposcopy. It does create anxiety, but in essence, they equated this as a one-to-one. The other problem is that they fail to recognize that Canadian screening programs, for the most part, are getting organized, but there are various levels of being organized. That some use a population database, are able to use a call-recall system, and very few provinces actually have a fail-safe mechanism where if you have a high-grade lesion and there's no action, that there is identification of this individual, and then the patient is identified and referred on for ongoing treatment. Well, what our program can offer in Manitoba is that we're able to provide each caregiver a screening history based on their past history. We can send letters to physicians and women when, again, they have not presented for a abnormal Pap test result for their next step in terms of management, being our fail-safe mechanism.
Tannis Wilson has joined the conference.
We can coordinate education and awareness for the public and healthcare providers as we're doing today. But behind the scenes, we can provide a quality assurance for healthcare givers. We give report cards to both healthcare givers, the cytology lab, and colposcopists. And in the future, we'll be able to collect and provide with the history, the HPV vaccine history for individuals who've been vaccinated, and be phasing and reminding letters to patients we're able to do for Pap tests. Well, the key thing about cervical cancer is the identification of pre-invasive lesions, and this is what decreases the incidence of cervical cancer. It also allows us to look at a stage shift that we can identify women before they have symptoms. They're asymptomatic, and that's what a Pap test is all about, is to screen an individual population of women using a test in an environment where patients are asymptomatic and have a normal cervix. So we're now seeing patients, obviously, instead of advanced stage disease, as being early stage disease before they have symptoms, which translates into a better prognosis. So That basically would mean that for women in countries that don't have a Pap smear screening program, the case-death ratio is virtually 2 to 1, so a 50% chance of dying of cancer, where it's roughly 25% in Canada. And this is what you see with screening, is that you decrease the incidence of both cervical cancer as well as the mortality from cervical cancer by doing Pap smear screening. Now, the reality, unfortunately, is that we don't have a perfect test, and we're not going to prevent all cervical cancers. It is unrealistic. I mean, that would be an optimistic goal if we could do this, and maybe sometime in the future that will be a realistic statement, but today it's not. Our screening tests aren't perfect. We do have cancers that have patients have had regular Pap tests, but they failed to identify these lesions in these individuals, and they've gone on to have cancers despite the fact they've done their job, having Pap tests with good primary health care givers, but still developing a cancer. And vaccination opens up a whole new door, prevention, in terms of its ability to prevent not only cervical cancer, but also other gynecological cancers, head and neck cancers, and perinatal cancers. Right now, the uptake is not perfect, and the vaccine that we have isn't perfect either. So the fundamental goals of treating patients is to maximize the benefits of screening, identify these precancers that are most likely to progress to invasive disease, while minimizing potential harm. So, i.e., trying to identify or not identify those individuals that have transient HPV infections that really mean nothing in terms of putting a person at risk. So with anything, you have to look at risk benefits. So the benefits, obviously, is to reduce the incidence of cervical cancer, reduce mortality. What you want to do is avoid potential false positives, so i.e. a Pap test that has low probability of progressing to something or having a high-grade lesion, let alone progressing to cervical cancer. Unfortunately, there is false negatives with Pap tests. It's not a perfect test, and the sensitivity of a Pap test is roughly 51%. There's an anxiety that goes along with Pap tests, the stigmatization of actually being labeled as having an abnormal Pap test, and also the perception of increased risk because I've had a Pap test that's abnormal. And again, not all Pap tests are equal. I mean, this may apply to somebody who's got a high-grade lesion, but really doesn't apply to somebody that often has a low-grade lesion. There is discomfort and bleeding that occurs with colposcopy examinations, and ultimately we can look at leaps or lets where in essence there is harm as far as the future goes for some of these young women who have these procedures, and leaving them with a cervix that's incompetent and they have a premature labor. So again, the sensitivity of Pap test is roughly about 51% overall. There's sort of changes that have happened out in the literature that have prompted changes in guidelines, not only in this jurisdiction but other jurisdictions. It's been the knowledge of the natural history of sin. So we know that a lot of low-grade lesions will regress. A lot of high-grade lesions may not necessarily progress, and that progression period of time, if anything, is over years to decades. We're now able to link cervical cancers and our knowledge.
Jennifer McPhail has joined the conference.
High-risk HPVs, and we can also link what really was developed from a high-risk HPV infection to a high-grade lesion. So, in Canada, and in Manitoba, you're going to see
has joined the conference.
You're going to see approximately 50 women with cervical cancer in this province each year. In Canada, it's roughly about 14,000.
Julie Desjardins has joined the conference.
Again, when you look at the probability of a woman having an abnormal Pap test, for every cervical cancer, we're going to see 300 women who've got abnormal Pap tests each year. So obviously the mathematics would suggest that not each one of these women would progress, if left untreated, to cervical cancer. Again, even if you look at high-grade lesions, there's an interesting phenomenon that we're seeing more carcinoma in situ, and this really applies to squamous rather than adeno in situ. We're seeing an increased ratio of squamous carcinoma in situ to cancers that with the starting of Pap tests was roughly about 3.6 to 1, so we are 8.4 to 1. We may well be seeing more disease out there, although the incidence of cervical cancer is really still decreasing. It may be that we're actually have more significant lesions that are appearing in our population. Now, again, not all these lesions progress, and this is a meta-analysis that was done by the Australian group, and what it shows is that if I have a low-grade lesion, I have a very high chance of regression. If I have a high-grade lesion, a greater chance of progression. Now, realistically, this is a general population. It's taken all women, so if you look at the probability of somebody who's got a histological diagnosis of CIN1, the probability of the lesion regressing is about 57%, of a lesion persisting, call it a third, and there's only about a 10% chance of it progressing, but a low probability of progressing to cancer. Our data with high-grade lesions is unfortunately more muted because a lot of these lesions we treat, so we don't know what the true natural history of a high-grade lesion is. There's a interesting study that was done in New Zealand, and it was done by accident where a community was not treated, patients in that community were not treated for high-grade lesions. And what they saw in this area was 30% of people developed a cancer over 30 years. So a low probability, not a low probability, but a probability that wasn't what we expect of individuals developing cervical cancer, but over a long period of time. So not a high probability of cervical cancer.
Has joined the conference.
Now, patients who are treated, usually about 1% of patients will progress on to invasive disease in the same community. What's been more interesting, again, this starts back about 13 years ago now, is the link between high-risk HPVs and cervical cancer. So the association of having a cervical cancer, virtually about 99.7% of all these cancers are linked to high-risk HPVs. And that's to make that distinction because not all HPVs are equal. There's a lot of other HPVs, another 13 genotypes, that aren't really associated with cervical cancer, whereas 17 are. So if you look at how this translates into a population of women, you see a lot of HPV-related disease in the population. There's a peak that occurs in women up to age 30 years of age that sort of plateaus off. And there's actually, although this diagram doesn't show, there's another peak that you see in North America, which starts increasing again. In other jurisdictions, such as Africa, this continues to just continue to go and drop down. So there's a lot of HPV-related diseases. Most of this HPV-related infections give us these low-grade pap tests that we see, but very few would actually progress on to a truly precancerous lesion. And you can see the peak here of precancerous lesion pretty well at about 10%. And again, the incidence of cervical cancer right below that. So what overall this whole diagram means is that a lot of these HPV infections regress. We don't see them. We see some of these precancerous lesions also regressing without treatment, but we do see some of these, unfortunately, progressing to something such as a cancer. Now, this is the other interesting thing that's coming along, is that when you look at not all HPVs are equal, is that when we look at primarily 16 and 18, is that a persistent infection with HPV-16 over a period of 10 years is associated with an incidence of carcinoma in situ roughly about 18% of the time. A persistent HPV-18 infection during this period of time is associated with approximately about a 14% chance of developing carcinoma in situ. But all the other high-risk HPVs that we have roughly a low incidence, less than 5% chance of developing into something like a carcinoma in situ over this 10-year period of time. So again, we'll start seeing persistent HPV as a risk factor, but it's usually the persistent same genotype over this period of time that puts a person more at risk. So there is a document that hopefully all of you have received that basically gives you the rationales for us changing our guidelines. These recommendations really apply to women who are sexually active or have been sexually active. And again, a pap test is designed to screen an asymptomatic population where the cervix is closely normal. Patients who are symptomatic or have an abnormal cervix should be evaluated. They do not apply to patients who have never been sexually active, women who've had a hysterectomy for benign reasons, individuals who are immunocompromised, and we have to sort of tease this one out a bit. It's easy to understand that patients are immunosuppressants for organ transplants, but we have to watch patients who are HIV positive if they have low CD4 counts, they probably carry more of a risk than patients that have high CD4 counts. And again, patients with cervical cancer should be evaluated, if not by a close clinical examination, by colposcopy. So our recommendation basically is not to screen women under the age of 21, even if they are sexually active and they have been sexually active for a long period of time, and virtually the harms of these people outweigh the benefits. This is the incidence of cervical cancer through all age groups in Canada during 2003, and you can see the incidence of cervical cancer in this less than 21-year-old age group is very low. And in fact, in Manitoba, over the last 30 years, we've only seen 3 patients with cervical cancer at the age of 21, and in 2 of these 3 patients that I'm quite aware of, that none of these patients, those 2 patients, Pap tests would not have protected them from developing cervical cancer. So the incidence of cervical cancer in the age 21 and under group is extremely low. Another way of looking at it was presented, published in the SOGC journal, the incidence of cervical cancer in this age group, despite looking at Pap test screening that's been in most jurisdictions across Canada quite robustly, is it really hasn't impacted the incidence of cervical cancer in this age group at all. It's been sort of static at less than 0.3 per 100,000. There's been some drop of the incidence of cervical cancer, which suggests that maybe there is a benefit of Pap screening in the 21 to 25-year-old age group, having dropped the incidence from 3.2 to 1.2 per 100,000. And you can see that when you start talking about older age groups, you can see the impact of screening having much greater benefits, dropping the incidence from 11.1 to 6.3 per 100,000. Another way of looking at it is what's presented from the U.S. Task Force in terms of the incidence of cervical cancer increasing as the age group increases, whereas when you look at sort of potential false positives, you can see it on this curve dropping down. So young patients have infections with HPV as an example that have very little consequence in them developing disease, so giving a false positive Pap test. And again, as time goes by, these incidences decrease. So again, brings some rationalism to starting screening. Individuals in this age group, and this is taking a fairly high-risk population in California, between the ages of 13 to 21, you can see that patients who were diagnosed with low-grade lesion, virtually 91% of patients had a complete spontaneous disappearance of their abnormal Pap test over a period of time of 3 years. And there's only about 3% of patients progress to a high-grade lesion, not necessarily a carcinoma in situ, but high-grade defined as moderate or greater. Again, when you look at how these Pap tests in this age group map out, again, using the California group, people in the age group 13 to 24, if they had a Pap smear demonstrating ascus persistently, most of these individuals did not have any abnormality. 6% of people would have a carcinoma in situ. Again, if they had an ASC-H, 43% of people had a normal-looking cervix, and only 10% of people had carcinoma in situ. People who had L-cell, half of these patients had no histological abnormality of the cervix. Only 6% of people had carcinoma in situ. And even patients who had high-grade Pap tests, the cervix was clinically normal 45% of the time, and about a quarter had a high-grade lesion. So again, if you look at the overall incidence of carcinoma in situ in this population, it actually was only 6.6% when you put the entire grouping of patients together. What about high-risk groups? Well, we're all concerned about young girls who are sexually active at a very young age. The Canadian Task Force, looking at the literature, did not find any higher incidence of cervical cancer or higher mortality in this lower age group, whether or not they started sex early, had multiple partners, or even were of Aboriginal descent. If you look at the probability of having a high-grade lesion, you can see that it decreases with time. Some of this is due to the fact that we identify these high-grade lesions at this point, and the chance of a second Pap test identifying something that's high-grade in the future becomes less probable. So again, the rationale to start screening at 21 and above and not to screen women under 21 is that cancer tends to be very rare in the adolescent age group, and our Pap tests have not impacted this age group over the last 4 decades. These cancers may not be prevented by cervical cytology, and again, in our Manitoba experience, that was the case in 2 out of 3 patients. There's a high probability of a lot of these low-grade lesions spontaneously regressing, and again, there's potential harm with over-treating these individuals as well. Now, in a transition, obviously, there's individuals who are under the age of 21 who've had Pap tests, and again, if they've had high-grade Pap tests, I don't think you can ignore them. They should be referred on to colposcopy, but those patients who've had low-grade lesions, you can stop at this point doing Pap tests and reinstitute Pap test screening at age 21. So again, there's values to seeing these young individuals, again, to assess potential health risks for them, help in their family planning contraceptive decisions, and again, counseling the benefits of screening and treatment of any STIs. Screening interval, there's room now to look at increasing our screening interval. In the absence of any abnormal cytology, we can screen every 3 years. And again, the benefits here is to get maximum benefits without harm. Virtually the renal benefits, you can see the incidence of cervical cancer decreasing in virtually all age groups, and I know this is a busy slide, but again, if you look at the adolescent group, no change in the incidence of cervical cancer. As the age groups get greater benefits in terms of screening, in terms of picking up significant lesions that have a probability of progressing into something bad, such as the cancers, and that's why we see this decreased incidence, is because of your ability to identify these high-grade lesions and for these lesions to be treated to prevent progressions. So again, if you look at the interval, probability of decreasing the incidence of cervical cancer, really there's not much difference if we look at screening on an annual basis versus biannual versus every 3 years. But when we start getting into longer intervals, you can see that there is benefits to screening in intervals less than 3 years intervals, but nothing, or we lose that benefit if we start increasing interval beyond 3 years. Another way of looking at it is the odds ratio of screening intervals in terms of reducing cervical cancer is 1.2, whereas, and again, that's not clinically significant. So again, looking at 2 or 3 years really is no difference in terms of protection. Beyond the 3 years, this is where we start seeing an increased incidence of cervical cancer and the benefit of maintaining our intervals at 3 years. Now, in terms of stopping screening, individuals who've had regular Pap tests, again, there's not a strong definition in terms of what is a good screening index, but most people will say that if we've had 3 negative Pap tests in the 10 years, is that we could stop screening at this point, and that's a fairly usable definition that most jurisdictions use. Individuals who've had high-grade lesions in the past are more at risk of developing cervical cancer in the future, and they should continue with cervical cancer screening. There is less data that supports a 20-year period of time, but it's a time period that most major jurisdictions have recommended. So how does this match up to the other jurisdictions in Canada? And I'm just going to quickly go through this because, I mean, there's a lot of data on the slides, but virtually most jurisdictions, from Alberta right through to Nova Scotia, don't recommend screening in the less than 21-year age group. British Columbia's guidelines from 2010, I'm not sure if they're going to update their guidelines, started suggesting screening at from 3 years after sexual activity. But virtually, for the most part, most jurisdictions in Canada are not recommending screening under 21. Again, I apologize for the heaviness of the slide with the data, but in essence, looking at intervals, most jurisdictions are recommending screening intervals of anywhere from 2 to 3 years. And again, this is the Prince Edward Island, is right to Nunavut. Again, looking at intervals every 2 to 3 years. Jurisdictions greater than 70 use sort of this constant, if I've had 3 negative Pap tests in the last 10 years, is stop screening. The only jurisdiction that actually deviates this slightly is Quebec, which suggests using an age group of 65, and sort of the upper limits aren't as strongly developed in the literature. But for the most part, as long as you can demonstrate a person's had a number of normal Pap tests, call it 65, call it 70, is that one could stop screening at that point. So if you look at what's happening south of the border, this was the same opportunity that a lot of the major jurisdictions in the United States, they had a conference that was convened last fall, and it was, if anybody is familiar with some of the guidelines in the United States, is these major organizations, the American Cancer Society, the American Society of Cervical Clinical Pathology, and the American Society of Cervical Pathology, had different guidelines and had different guidelines for probably the last 10 to 15 years. So as a group, they did something different than the Canadian Task Force did. They got together. They actually brought together about 25 other different organizations. And in essence, they came up with guidelines that would be uniform across the United States in contrast to the process we had in Canada. But again, they're not recommending screening under ages of 21. They recommended cytology as the sole test for screening, ages 21 to 29. They promoted HPV testing in the United States, where from the ages of 30 to 65 would have co-testing every 5 years, again getting that interval of protection with that HPV provides. If one is not doing HPV testing, intervals of every 3 years. And virtually individuals who've had regular Pap smear screening is to stop screening after age 65. Again, the same group of individuals who've had hysterectomies, not recommending screening for that population as well. This is an old statement, but it was again quoted again by the Canadian Task Force, and it's not an original statement to them. It's a statement that virtually we all appreciate, that the greatest reduction in cervical cancer is to reach those populations of women who are not having Pap smear and trying to screen those individuals. Also, those patients who have had relatively infrequent Pap tests. So if you look at how this translates to Manitoba, 50% of the patients that we see in Manitoba, so you can virtually say that about 25 patients that we see in Manitoba don't have Pap tests and they present with cervical cancers or have never had Pap tests. 25 will have had Pap tests, but maybe the last one was 6, 7, 8, 10 years ago. And there's roughly about 25% of individuals who will be doing their job, going for regular Pap tests, but unfortunately still developing cervical cancer. Now, these are the guidelines that are available to you. They are on the web, so I'm not going to go into more detail, but in essence, they're available to you. And again, this is the management guidelines that come part and parcel, so it's not just recommending frequency, but in essence, recommending how to manage these abnormal Pap tests and where we go from there. The cervical cancer screening program can provide you the screening history, so we're trying to avoid an opportunistic screening program where if I'm down there, let's do a Pap test anyways, is to take patients' histories and it's available to you through the cervical cancer screening program. You can get the data by just even faxing it into the program, and we can give you the patient's history available to you to say what the Pap smear history is, and you can help tailor the screening program to that particular individual. Now, again, the importance is to help patients understand what a Pap test is, and hopefully by patients understanding what a Pap test is, it'll enforce or help and enable them to participate in regular screening programs. Now, the more patients are educated about the value of Pap tests, the better, but we also have to educate them about the harms. We've taken this scenario of more is better, but unfortunately what we're finding is that more is not beneficial. It actually does harm. The harm basically is if I have these low-grade Pap tests, if I'm going to develop a cervical cancer, patients are insisting on treatments that unfortunately do very poorly with these low-grade lesions. And again, a lot of these low-grade lesions would disappear without treatment. So it's trying to tease out those individuals that have high-grade lesions that need to be treated, and that would decrease their risk from those individuals that have low-grade lesions that in essence were over-managing. So look at other educational messages that we should provide is that we should try and normalize cervical Pap tests, and more so now that we're talking about its associated with HPV, is try and normalize it. We label it as the most common STI in North America, but virtually all of us have had HPV in our life. We just may not be aware of it. Some of us may get HPV-related diseases, which in essence has that association. But again, being as common as it is, maybe it's not truly sexually transmitted as we thought. And there's some data to break this into, or sort of challenges the thought process. There's no question that when you look at the probability of having cervical dysplasia, is that it seems to be easily transmitted. Virtually the probability of my having or anybody having cervical or HPV infection is roughly 75%, if not higher, long term. It's not associated with infidelity or promiscuity. It basically is a very common virus, and again, if the vast majority of us have it, again, probably does not suggest anything more than a very common infection. The other reality is, even though I have this infection, I could have a high-risk HPV, such as 16. They can be persistent, but not necessarily mean that I'll progress on to develop disease. Most of these infections clear, so I'll have an HPV infection. It may come, go, never even being aware of it, but again, if I identify it, I need to be followed and managed accordingly. Condoms have their benefits, and there's some data that if I use condoms reliably, that it will decrease my incidence of HPV. Definitely, we have to ensure that condoms have their benefits in their place, especially in the prevention of other true STIs such as chlamydia and gonorrhea. And even with the HPV vaccine, it's not a perfect vaccine. The two that are currently on the market have benefits in terms of preventing maybe 70% of cervical cancers and a higher percentage of patients with precancerous lesions, but we still need to screen these individuals with Pap tests. And the best promotion is having regular Pap tests. Again, looking at sort of regular frequencies of Pap tests, and again, as our recommendations every 3 years. We don't gain by doing Pap tests every year. Again, the probability of having a lesion progress happens over a long period of time that theoretically a Pap test should pick up. The program can provide you with educational materials that can help educate your patients, and it's available in multiple languages. We can also direct them to websites to help increase their knowledge. So the burden is not just on us in terms of explaining things to patients. The burden is on all of us, and we have these educational tools to help us. And again, the screening guidelines are available on the web so that, again, this is a moving target. As knowledge increases, we're going to find that guidelines are going to have to be adjusted accordingly. So at this point, there's opportunity for questions. So I can probably take some of the questions from the chat area.
You are no longer muted.
To let you folks know, we've now unmuted everybody, so everybody should be able to hear everybody. So unless you are taking the floor and have a question, we might encourage you to just be as quiet as you can. So we'll start with the questions from the chat box here, and then we'll open up the phones to take some questions as well.
So the question is, what % of persistent high-grade lesions, infections clear? I like to be able to tell my patients a rough number. Generally speaking, you could say that when you start getting moderate or greater, 43% of patients with moderate dysplastic lesions will still progress spontaneously. About 17% of these patients will progress. When you start getting to a lesion like carcinoma in situ, is that not all these progress. Roughly about, you can see that 30% of patients will progress over 30 years of time. Some of this will clear. When you try to take this data and apply it to
Dana has left the conference.
Women under the age of 21, what you'll see is the fact that these numbers are more robust, is that the high-grade lesions will clear more often. They tend to be lower in frequency, but have a higher probability of clearing spontaneously. But today, we're still talking about treating patients even under the age of 21 who've got a carcinoma in situ, rather than following clinically.
So we've got a question from Cheryl Campbell. The question is, Dr. Lotocki just said that the resources are available in multiple languages. Is this true for the pamphlet shown or just the bookmarks? At this time, we have just the bookmarks that are translated into 29 different languages. As an option, we do have translation services for some parts of Manitoba that we can help facilitate so that an individual who doesn't necessarily speak English as their first language, we can definitely attempt to try and translate that information for them.
So the next question is, if a woman is discharged from a colposcopy, when should our next Pap test be scheduled? I think we have to look in terms of why she was in the colposcopy clinic. So if she was in the colposcopy clinic, had a high-grade lesion, was treated, unfortunately, she's going to need annual Pap tests. And what literature there is suggests that this Pap test frequency should occur for a duration of about 20 years, although the time period got less definite credibility in the literature. Again, somebody who's got a low-grade lesion, theoretically, is that if she's completed a normal follow-up, then I think she could be treated as if she was at normal risk, and we can look at intervals that are consistent with her normal sedation for years. Question, is there any change in antenatal Pap test recommendations? Again, we look at sort of an antenatal Pap test as an opportunity to screen. So if we've got the information this patient's participated in regular screening, just because we're doing an antenatal visit, we don't have to do a Pap test. We could do our other cultures and tests that we need to do. If she's not participated in previous screening, we could take the opportunity to do a Pap test. Is the last cervical cytology result available for women under 21? As an also asked us, do we wait until she turns 21 to begin to remain, regardless of how many years remain until she's sexually active? The short answer is yes. I think there's more harm in this population. If she has a high-grade lesion, fair enough to send her on, but if it's a low-grade lesion, we can do is stop doing Pap tests until she turns 21. So the next question is a 33-year-old who had a ELSA in 2007, a Pap test in 2007 showing severe, so I guess I presume that's a repeat. Colposcopy showed mild with a planned leap. Culp was negative, showing squamous metaplasia. Pap 2008 is negative. Yearly Pap tests are negative since that period of time. Again, it depends whether or not she had this leap. If she did not have this leap and there was no true high-grade lesion, that Pap test that we had here that showed severe dysplasia may have just been a blip. And I would say that she probably could be managed just as if she was having routine screening and go every 3 years.
On young women who haven't yet had their babies, they make the cervix weaker. And they're at risk.
Right here. Discharge from colposcopy.
Yep. If a woman is discharged from colposcopy, when should her next Pap test be scheduled? Again, high-grade lesions, if she was treated successfully for, probably continue for 20 years. If it's a low-grade lesion, that basically successfully disappeared.
You are now muted. You are no longer muted.
Okay, folks, I think we've covered most of the questions in the chat box, and we'll open it up to the phones now if anybody has any additional questions that have not been addressed yet.
Hi there.
Hi.
Hi, this is Jennifer Schmidt from UBO Center in St. Vital. I have a question about commencing Pap tests at age 21. Previous guidelines stated that we should commence Paps after 3 years of sexual activity and not. So I'm just kind of wondering, and I know our doctor is wondering the same thing today about when should we commence after age 21. For example, say a client has only been sexually active for a year, they're 21. Should we go ahead and start the first Pap then?
I think the short answer is probably at this point, yes, it's an arbitrary decision. When you look in terms of probability of her having significant dysplasia with just a short period of sexual activity, probably it's low probability to have a high-grade lesion. So I think that it's fair enough to look at starting Pap test at that age as an arbitrary age that we're talking about.
Okay, thank you.
Another question from the chat room: patient with a frequent unsatisfactory Pap test result qualified for colposcopy. This has been a guideline that we had to revisit. When you look at what unsatisfactory means and tease it out in the literature, individuals who have persistent unsatisfactory
You are now muted.
tests because of a lot of red cells or white cells have a higher probability of having cervical cancer. If we look at those individuals that have a persistent unsatisfactory Pap test because of lack of epithelial cells, so i.e. probably the women we're talking that's menopausal, she does not have that same risk. And again, it's not surprising that we're not going to have a lot of epithelial cells on a Pap test if the person is menopausal. So again, if she's asymptomatic and you don't have obscuring features that give you an unsatisfactory Pap test, I think we could follow that patient without colposcopy. There is room to consider maybe using estrogen in these individuals prior to repeating a Pap test that has been shown to decrease the possibility of an unsatisfactory Pap test because of inadequate or a shortage of epithelial cells. So next question is if it's been my practice that I can see a visually abnormal cervix regardless of Pap test, I should refer directly to colposcopy. Is that still appropriate? The short answer is yes. Is that, again, we have to remember, maybe going back a step, that not all cervixes look alike, but if there's a concern in terms of is the cervix manifesting a cancer, not manifesting cancer, I think it's fair enough to have somebody look at the cervix, at the patient's cervix with a colposcope. The reality is that usually most cervical cancers, when we look abnormal, will either be a sort of a fungating or cauliflower type of lesion on the cervix or an ulcerative lesion on the cervix. But again, some of the most interesting diagnoses of cervical cancer made have been individuals who look at the cervix and say it's abnormal and not depending upon a Pap test to pick up abnormal cells to trigger the referral. I think we've sort of answered this next question. Somebody who's had colposcopy for a high-grade lesion. The data unfortunately would suggest that we should follow these patients for a prolonged period of time with annual Pap tests. And again, the number that's been used in the various jurisdictions in the U.S. as well as Canada have been to follow these patients for 20 years. There's some background noise that actually somebody didn't hear. So an individual who's had a previous LCIL can be managed with routine screening once things are normal. So again, just treating it just routine Pap tests. Women who are pregnant when they present at age 20, should she have an abnormal Pap, or should she have a Pap test? Unfortunately, what you're going to see, two things with people who are pregnant. Again, we've taken this as an opportunistic reason to screen, but on the same note, we tend to see Pap tests that tend to be unsatisfactory in this population, but we also tend to see more false positive Pap tests. So I would not, just because she is pregnant, do a Pap test even though she's under the age of 21. Okay. So we have not a question, but a comment about who can be included in the cervical cancer screening program. I understand currently only females can be included. I have a female-to-male transgender client. They're all changed to male, but he still has a cervix, so a Pap test is necessary. That's true. This individual should continue to have Pap tests. And interesting enough, what you see in this group, I have no, in fact, the literature is quite sparse on this issue, is because of testosterone supplementation, these individuals tend to have high false positive low-grade Pap tests. And when you examine their cervixes, their cervix tends to be quite atrophic, probably because of testosterone. But again, the key thing here is if it is a high-grade lesion, yeah, they still need colposcopy. If it's a low-grade lesion and it's persistent, probably colposcopy as well. And again, is this available on the web after the presentation is complete?
The short answer to that is yes. We're hoping to get it up as quickly as possible, and you can access that at getcheckedmanitoba.ca, which is our tri-screening landing page or website.
So the next question is, I'm a resident from Newfoundland visiting Manitoba for an elective. I was just wondering if you do an HPV DNA testing on women with abnormal pap tests. Well, Jennifer, you're miles ahead in Newfoundland with HPV testing. I mean, I hope that Manitoba will reach that barrier in the near future. There's a lot of activity to look at changing the paradigm for screening. So instead of using cytology, is to do HPV DNA testing in the future. So what HPV testing has been done in Manitoba to date?
Julie Desjardins has left the conference.
So what HPV testing has done in the province to date has been primarily a lot of research investigations, but in the same note, this is the direction that most jurisdictions are going, and this is one of the concerns I had with the Canadian Task Force, is that it was an opportunity to say that this is the direction that Canada should head, rather than saying that there's not enough data to say that it prevents cervical cancer.
You are no longer muted.
Are there any other questions from the phone lines?
Yes, this is 23 Canadian Forces Health Services. I have a question about a hysterectomy. If someone's had a hysterectomy for malignancy, should we continue vault smears, and for how long?
If the malignancy is endometrial cancer, probably just for 5 years. If the hysterectomy is for cervical cancer, I would say that should be the individual that should be followed for a longer period of time, and arbitrarily that time period has been defined as 20 years.
Thank you.
Anybody else with any questions from the phone? Okay. Well, thank you everybody for your attendance today. A couple of quick things before you leave us. If you are hoping to collect MainPro M1 credits, and you did not enter your first and last name in while you entered the webinar, please contact us. And our contact information is coming right up. Can you advance the slide, Bob? It would be very helpful if you could fill out our evaluations for us. Leslie will be sending those to you this afternoon, and that really helps us guide future presentations and to make sure that you're getting the information that you need for your practice. I'd like to thank Dr. Lotocki again today for being with us, and thanks very much to Leslie and Madeline for their hard work and organization and planning and supporting us to get our first ever webinar off the ground. So that was fantastic, and I hope it's a good medium to connect with everybody far and wide across the province. So I think we can call it quits. Thanks everybody, and be sure to contact us if your questions were not answered today.
Thank you.
Thank you very much.
Cindy
Has left the conference.